So, hi everyone. I thought to discuss one of the important topic that is about summary of American Society of Breast Surgeons recommendations for breast cancer screening, and also what are the various uh, points that they have mentioned, and we should know about all these points. So I'll try to summarize them. So, this is a short summary where they have mentioned about four types. Uh, like first is A and B density of the breast. Second is the C and D density. So that is for the woman with average risk. So what is meant by these densities? So basically, class A density means where the breasts are fatty, and the class B or 2 density means there is a scattered fibroglandular density. Then class C or 3 density means heterogeneously dense. Then class D or 4 density is extremely dense. So as the density increasing, the class is increasing, we can say A, B, C and D. Then so they have mentioned for class A and B density there should be a annual mammography, preferably 3D, that means tomosynthesis should be started at the age of 40, and there is no need for supplemental imaging. Then for C and D density, uh, the annual mammography starting at the age of 40 with the consideration of supplemental imaging. So here we can see the difference, that in A and B there is no need for supplemental imaging, and for C and D there is a need for supplemental imaging in women with average risk. Then women with higher than average risk are considered as in which there is a hereditary susceptibility from pathogenic mutation carrier status. Then if there is a prior chest wall radiation at the age of 10 to 30, that is very important. And then if there is a predicted lifetime risk more than 20% by any model, there are many models to uh, find out these risks. Then strong family history. So for the above two group of people, there should be an annual MRI starting at the age of 25. uh, Specifically they have mentioned about the 3D modality, and it should be starting at the age of 30. And for these two groups, which are like these ones, annual mammography and access to supplemental imaging, and it should be like MRI should be preferred starting at the age of 35 when recommended by their physician. Then there are two other groups, women with prior history of breast cancer where the age is more than 50%, where the age is more than 50 with non-dense breast. So here also there should be an annual mammography. Then women with prior history of breast cancer at the age of less than 50 or with dense breast, the annual mammography along with the supplemental imaging. Then we come to the few points that it has been mentioned there, and we'll try to understand them one by one. So women age more than 25 should undergo formal risk assessment for breast cancer. So that we usually read in triple assessment, that is for diagnosis actually, but we are here talking about the screening thing. So that is the thing which we have to remember. Then the woman with an average risk of breast cancer should initiate yearly screening mammography at the age of 40. So this is very important. This came from the ACR, that is American College of Radiologists, and the other concerning authorities. Then women with a higher than average risk of breast cancer should undergo yearly screening mammography along with the supplemental imaging, and this screening should be initiated at a risk based age. And then this screening mammography should cease when the life expectancy is less than 10 years. Then there are few guidelines which are included in this only. So basically these all screening guidelines come into the picture uh, with the RCT that actually took place around between 1963 to 1991. Then these were the trial actually were taken place in the United States. These were 9 trials where around 6,60,000 women with average risk for breast cancer were included. But while doing or while preparing these screening guidelines, and over the time there have been many advances. If even if we talk about the screening breast lumps, so there should always be one thing in mind, that is there should be a balance between overdiagnosis versus the what are the outcome benefits of early detection. So American Cancer Society also updated about the guidelines for the women with average risk, and they have recommended that this screening mammography should start at the age of 45 and continue yearly between ages 45 and 54. Then for the women age 55 and older, they are recommended to undergo biennial screening with an opportunity for yearly screening mammography. Then they have mentioned like what are the changes that happened during last 30 or 35 years. So that means in the US population only, it was found that this demographics of American women in the age group of 40 to 49 year has grown by approximately 10 million since the era that launched the screening mammography trials, yielding an expanded population struggling with these decisions whether this should be happened at 40s or 45 or 50s. But with uh, overall conclusion, it was found that the screening should be done or should be routinely done at the age of 40 and afterwards. Then American College of Radiologists and Society for Breast Imaging recommends annual mammographic screening, which should begin at the age of 40 for women of average risk, and they suggest that women with higher risk should start mammographic screening earlier and that they may benefit from the supplemental screening modalities. Then for women who are at a risk because of the genetics and where there are their untested first degree relatives, those with a calculated lifetime risk of 20% or more, or those with a history of chest or mental radiation therapy at a young age, for example for any lymphoma, the ACR and SBI recommends supplemental screening with contrast enhanced breast magnetic resonance imaging. Then this breast MRI is also recommended for women with a personal history of breast cancers who have dense tissue, and those with a history of breast cancer diagnosed before the age of 50. Then there are few more points. The 10th point and last point, I think, sorry, that is ACR and SBI further supports considering additional surveillance with MRI for women with biopsy proven atypia, especially if other risk factors are present. Then there comes a role of risk assessment. For this, there are two groups which are specifically made. I mean, like the one group where the age is 25 or when the first seen by a breast physician. So these are considered under high risk, and then age 30 or above. So these are the groups. In group 1, assess family history of malignancies and determine if the woman has a prior history of atypical hyperplasia or lobular carcinoma in situ. Then for age 30 or above, assess all these three risk factors and also estimate breast cancer risk using the various models. One of them is Tyrer-Cuzick model. I'll discuss what are these models are all about. Then also update risk at the regular interval. Then so we'll discuss about the breast cancer risk, what is absolute risk and what is relative risk. So if you talk about absolute risk, so absolute risk is actually the individual's likelihood of developing breast cancer. For example, it is based on the number of people who will develop breast cancer within a certain time period. So it can be stated as percentage. So if we talk about the population in the United States, so it says that around 1 in 8 women will develop breast cancer over the course of their lifetime. That means 12%. So the absolute risk of developing breast cancer during a particular decade of life is lower than 1 in 8. Then the younger a woman is, the lower the risk is. For example, a woman who is at the age of 30 and there are no other risk factors present, then the overall risk is 1 in 2 to 8. That means 0.44 in the next 10 years. And on the other hand, if a woman who is 60-year-old and there are no other risk factor, this chances is around 1 in 29. That means 3.49% in the next 10 years. Then we come to the next, that is the relative risk. So relative risk is when we compare one group risk of developing breast cancer to the other. And then we have certain recommendations like women with average risk. So for women with average risk, they should screening mammography programs at the age of 40, which we have already discussed, and this should cease once the life expectancy is less than 10 years. And this 3D mammography, that is tomosynthesis, is available in USA from like last 10-15 years, and it helps in improve the sensitivity and specificity of the mammography, particularly for the women those with the non-fatty breasts and in assessment of non-calcified lesions. And it is preferred over the 2D units because it was found that the current 3D mammography units is not associated with like any higher risk of radiation exposure than the traditional 2D units. Then for the women with higher than average risk, so as per NCCN guidelines, it was found that women with a BRCA gene mutation or other germline mutation known to predispose to a high risk of breast cancer, and then women with a history of chest irradiation between the age of 10 and 30, then women with a greater than 20% estimated lifetime risk of breast cancer depending upon the various models, for example Claus model, Burka Pro and Tyrer-Cuzick models, so which include all the women who are having atypical hyperplasia or LCIS. So these are the group of people which are considered in higher than average risks. Then we have women with prior history of breast cancers. So in these group there is always a higher risk for an in-breast tumor recurrence, which is called as IBTR, or a new primary breast cancer. And then for women who have undergone unilateral mastectomy, the contralateral breast should be followed with yearly screening mammography. For women who have undergone BCS, An annual mammography for the cancerous breast should be performed for local as per local institutional protocol. Then, in addition, American Society for Breast Surgeons support access to supplemental imaging for women with a personal history of breast cancer who have either dense breast tissue or were under the age 50 at the time of diagnosis. Then other supplemental screening modalities include contrast enhanced MRI, ultrasound, molecular breast imaging, and contrast enhanced mammography. Then for the population, like older women, it was found that as per the previous RCTs, that they have excluded all the women which are older than 74, and as per United States Preventive Services Task Force, it was found that uh, like for the age group more than 74, it is only benefit of having any benefit if there is a life expectancy of more than 10 years. So usually it was found that if the woman is having any sort of comorbidities, then there is of it is of no benefit, and if there are no comorbidities, then one can continue even after the age of 74. So thank you for staying with this discussion. I will keep discussing such things uh, in future also.